What you are looking at now is called a PUBS. It is a percutaneous umbilical blood sampling. What we're doing here is we're actually taking fetal blood samples, and this is a possibility that the baby can have a transfusion done this way. So what they're using is they're actually using DNA, and chronic villi is the sample that they're basing it on. What happens is a needle is inserted directly into the fetal umbilical vessel. Usually preferable is the vein. It is under ultrasound guidance. Ideally, what happens is the umbilical cord is punctured near its insertion into the placenta. So what we're looking for is what we can actually assess from the sample is inherited blood disorders, karyotyping, malformations of the fetus. They can also detect fetal infection and assessment and treatment of isoimmunization and thrombocytopenia in a fetus. What can happen to mom is there's a risk of maternal blood contamination. A small amount of blood is actually taken immediately, and it is tested to ensure that it is actual fetal blood in origin. And it is tested by something called an AP test, but the other name for that AP test is Klein-Heyer, and it's a hyphen bet. So it's also known as AP test. This is the test that is done to determine and confirm that it is a fetal sample. Other things that could happen, possibly complications can occur. There can be a loss of pregnancy, hematomas, and bleeding from the actual site at the umbilical cord or in the umbilical cord. Transient fetal bradycardia can occur, bradycardia, or fetal maternal hemorrhage. Mom's complications are rare, but if she would have them, it would be a transplacental hemorrhage or just a hemorrhage in general. This can also allow a intrauterine transfusion if the babies are severely anemic. It can be performed 4 to 5 weeks earlier than if they did an intraperitoneal route infusion. One of the things you want to follow up if this test is done is we are continuously monitoring fetal heart rate for 1 to 2 hours after the procedure, and mom should be taught to do kick counts when she is discharged home. Okay, alpha fetoprotein. This was one of the markers that we are using to look at, or one of the markers that we're looking at on the amniocentesis. This is produced by the fetal liver, and increasing levels are detectable in the serum blood of a pregnant woman, usually about 14 to 34 weeks of gestation. They can do a maternal sample of alpha fetoprotein, and it usually has reasonable reliability, and it usually can be done anywhere between 15 to 20 weeks gestation. Once the maternal level of alpha fetoprotein is determined, it's compared with normal values based on each week of gestation. Values usually correlate with mom's age, weight, race, and if she has multiple pregnancies, or she has multiples that she's currently pregnant with, and if she is an insulin diabetic. Abnormal findings, what will happen is follow-up procedures include genetic testing, a repeat of alpha fetoprotein, ultrasound examination, and possibly amniocentesis. All of these tools and samples and procedures that can be done are in the mother-baby world are done together, and the more indicators that are done together, the greater that you have actually diagnosing the disorder. When we're looking at alpha fetoprotein, we're actually looking for neural tube defects. And then when we're looking at amniocentesis, we're looking at different genetic or chromosome anomalies. So they all kind of combine together for the most part. The other thing I want to talk about is multiple marker screens. During the first trimester, the screen can be done between 11 to 14 weeks of gestation. What happens is there's a measurement of 2 maternal markers. There are several different screens in this category. So the first one that can be done in the first trimester, they're looking at 2 markers. Those markers are a PAP-A. That stands for Pregnancy-Associated Placental Protein, and we also do a HCG. That's your human chorionic gonadotropin. They can also do the free BHCG, which is the beta human chorionic gonadotropin. This evaluation can also be used in combination with the nuchal translucency test. They can do a combination and use both. So when they're doing these markers in the first trimester, what are we looking for? What are we looking for as far as the assessment or interpretation of the test? We're trying to detect chromosome abnormalities, such as trisomy 21. So if I have a high level of HCG and I have a low level of PAPP, that is an indicator or a positive indicator of a chromosome abnormality. Now we're going to go on and say, okay, let's go to second trimester. So when we're doing second trimester testing or markers, and these are blood samples that are obtained from mom, we can do a triple or a quad screening. We are assessing for trisomy 21 and trisomy 18. If we're doing the triple marker, triple means 3 components, it's done at 16 to 18 weeks. We're looking at an MSAFP, we just talked about. That's the maternal sample of alpha-fetoprotein. We're also looking at conjugated estrol. Oops. And then we're also looking at the HCG. So if we have a baby who has trisomy 21, the maternal alpha-fetoprotein and the unconjugated estrol levels are low. The HCG is elevated. That's for trisomy 21. If we have low values in all 3 categories, that's an indicator of trisomy 18. Now I am running out of room. We don't have much left, so I won't add a new slide. So we're going to move on to the quad screen. The quad screen essentially is the same 3 components: the maternal alpha-fetoprotein, unconjugated estrol, and HCG. The 4th component that is added is called inhibin A. Inhibin A is a hormone from the placenta. So what happens in this component, you're actually going to have low markers in all 4 categories, and this is a possibility of Down syndrome or your trisomy 21. The last thing we're going to talk about is the cell-free DNA that is obtained from maternal blood. This screening is actually obtaining the Rh status, fetal gender, and parents transmitting single gene disorders. So they're doing this by amplifying DNA, and they're obtaining this information and the results. We're going to talk about the NST, or non-stress test. The non-stress test is actually looking at the heart rate patterns in the response to fetal movement, uterine contractions, or stimulation. In term babies, there should be accelerations associated with movement. The most common absence actually of a fetal heart rate acceleration, usually babies fall asleep. I had mentioned in a couple of slides before, babies are just like you and I, they take naps. They take a lot more naps though than we usually get to take naps. So the other reason that could possibly not see an acceleration with the heart rate is medication. If mom is on some type of a narcotic, beta blocker, that's going to have an effect on the movement and acceleration. This is a non-invasive test. It is done in an outpatient setting. The test itself, the only disadvantages is moms are coming in and they're usually required to have the testing done twice a week. It does have a high false positive rate. Usually only takes about 10 to 15 minutes in most cases. What are we doing? Mom comes in, she's seated, whether she's setting up in a semi-Fowler's position or she's in some type of like reclined chair. Slight lateral tilt, because if she has the slight lateral tilt, this is actually optimizing uterine perfusion, and we want to have perfusion going because we want to see those accelerations in baby. Remember, we do not want moms laying flat on their back. They're at a high risk for hypotension or supine hypotension. The baby's heart rate is recorded with a Doppler transducer and something called a TOCO. If you guys came in, I don't know if I showed everybody that came in into the mother-baby scenario. If not, don't worry, because I'm going to bring the TOCO in and we will see it in class. We only had the one portion. It's usually two bands with a little circular device, and one is measuring baby's heart rate, and one is measuring mom's contractions. And it goes around mom's abdomen like a belt. So that's what it's measured with. We are observing fetal activity and accelerations of the fetal heart rate. I'm going to show you some rhythm strips in the next couple of slides, so some of this will make a little bit more sense. Non-stress test and contraction stress test is what we're going to talk about for the remaining slides. We are also going to talk about this again in class because this is the stuff that shows up again in boards, and you're probably going to see it on a test. And you need to understand it, so we will go over this again in class. So what we're looking for is acceleration of the fetal heart rate. Sometimes babies fall asleep. They don't we can't always distinguish if they're accelerating with the fetal heart rate or not. So mom may be given a button that she pushes when she feels baby moves, and that actually puts a little mark on the rhythm strip. Test usually is completed for the most part no longer than 30 minutes. It just depends. If baby's wide awake and ready to go, it's usually 10 to 15 minutes. If not, 20 to 30 minutes. Don't get so hung up on the time frame. More time is actually required though if the baby falls asleep or we're not getting good tracing, so it may take longer. Some care providers may suggest to the woman to drink orange juice or give her some type of a glucose to increase her blood sugar. We said that if mom eats and her blood sugar's up, and that glucose goes to baby and that stirs baby up. The other thing that can be done is using vibroacoustic stimulation. This is essentially a little handheld tool that has this vibrating, buzzing sound that you rub over mom's belly, and that's another way to try to stimulate baby. So we're going to talk about interpretation. Before we talk about interpretation, I'm going to write on this slide some information about the strip, but I'm also going to talk about it again once you see the strip. So one of the things you need to know is each square is 10 seconds in time. So if I have 6 squares, and you'll see they're defined by 2 darker marks. That is 1 minute. You typically see on a screenshot or a shot 12 minutes in time. The top of the rhythm strip is baby, and when I say baby, I mean fetal heart rate. Your books like to vary in what they determine as a normal fetal heart rate. One place it says 120 to 160, other places it says 110 to 160. I'm just glancing through your book to see what your book actually says, because it will vary. Of course, when I'm looking for it, it's not so easy to find. Okay, so it's either 110 to 160 or 120 to 160. If these numbers change or we get something I find more definite as far as testing purposes, I will definitely let you know. We always have to establish baby's baseline anyway, and we'll talk about that some more. The other thing you need to know is at the bottom of the screen, that's mom, and when we talk about mom, it is mom's contractions. Okay, so let's move on and look at some actual strips.